I would like to at this point call up Dr. Jeffrey Zonder, who in our world of myeloma is really one of the major thinkers in this sphere, and you have him right here in your backyard here in Detroit, and he is going to come to tell us a little bit more deeply about how we treat myeloma. So Jeff, I'm going to turn to you, brother. Thanks so much for being here.
Thank you so much. Can you hear me okay? Like so? Where's...
They'll move it for you.
Oh boy, there's so much embedded animation. Okay, we're in trouble already. Before we've even started, we're in trouble. But thank you so much. And we're very happy. I'm speaking for myself and also on behalf of the Karmanos Cancer Institute. We're thrilled that we can engage with everybody like this here today. And this is the start of a super important effort here in the Detroit area. So my task today, in about 20 minutes or so, is to talk about how we treat myeloma. Now, as Joe said, this is a group with varying experience and knowledge about myeloma. Some people are patients who've been at this for 10 years or 15 years. Some people in the room are hearing about myeloma for the first time. And so my job, I'm going to sort of call back to certain things that Joe discussed about the diagnosis and symptoms of myeloma, and then I'm going to move quickly through that into treatment and sort of how treatment has evolved over the last 20 years or so, and sort of where we're at now, which is we're at an inflection point in treatment because we have some brand new therapies that are really totally changing the landscape, and that's what we're going to finish with. So we can skip right through this, and just to remind everybody, the reason that we're focused on this multiple myeloma, the second most common blood cancer, first most common in African American people, 30 to 35,000 cases per year in the United States. And if you could hit the next button, remember it presents typically with these what we call CRAB symptoms, calcium elevation, renal or kidney injury, and anemia, low hemoglobin. Those are the more common symptoms in African American patients at diagnosis. Bone disease, a bit less common, but when it happens can be quite problematic. This graphic, to be honest, is only slightly a cartoon. I mean, this is really what the bones look like in myeloma patients. The lesions are like holes in your bone. It weakens the bones, and you can look at that long bone from the leg, and you can see that when it's notched out like that with lesions, those are weak spots. And sometimes somebody's presenting symptom is bone pain, but sometimes somebody's presenting symptom is an actual fracture, and it can be in a long bone like this, or more commonly in somebody's back, in somebody's spinal column. If you have a lesion like that in somebody's spinal column, I'm going to show you pictures. If you hit the next slide, it's going to be in a few slides, but I show you some films, some different imaging modalities that we use to make the diagnosis. You'll be able to see the effects of those kinds of lesions in somebody's spine. Remember, we heard that everybody with multiple myeloma generally has that disease arise from a precursor condition, which we sometimes know about because blood work has discovered it, and sometimes we don't know about. But it was also, again, it was a VA study where they actually had banked samples of blood, and they were able to go back in time and look at blood samples of patients who had been diagnosed with multiple myeloma, and proved that, in fact, if you had gone back, if you had done testing years before, in some cases years before they ever had symptoms, you would have detected this precursor lesion, which we called MGUS. MGUS, again, it's an abbreviation, an acronym, and what does MGUS stand for? M and G stand for monoclonal gammopathy, which in plain English means abnormal protein, and then US means uncertain significance. It means you've detected this abnormal protein, but we're not really sure this is ever going to turn into a problem, because if we hit this, only about 1% per year, you can keep hitting the buttons, that's good. About 1% of patients with MGUS each year go on to develop multiple myeloma, and we're not actually very good at figuring out who those patients are going to be. That's the honest truth. We talked about the incidence of multiple myeloma in people of color, in people of African descent, being higher. And it is not because the risk of going on from MGUS to myeloma is higher. It probably starts back at the frequency of this precursor condition. Just like the incidence of myeloma is twice as high in African American people, the incidence of the precursor condition, MGUS, is twice as high. So when Joe mentioned about 5% or 1 in 20 people over the age of 70 have MGUS, double that number, and that's what you would expect in the African American community. So it's actually, MGUS is very, very common in the African American community. Hit the button one more time. And as we already heard, as this precursor condition is sort of evolving into full-fledged myeloma, there's this middle ground called smoldering myeloma, where the amount of abnormal cancerous plasma cells in the bone marrow is higher, where the risk of going on to develop these crab symptoms that we heard about in the next year or 2 or 3 is higher, but it's still technically asymptomatic, even though it seems to be in evolution. Okay, that's what smoldering myeloma is. All right, next slide. So how do we diagnose it? I mean, what typically brings patients to my clinic? It could be the results of blood tests, and so abnormalities in routine blood work, like a blood chemistry test, you stumble on an abnormal kidney function. A routine blood count, you find out somebody's anemic, and after you work it up, there's no obvious explanation. Sometimes it's an abnormal urine test, there's extra protein in the urine. Sometimes it's an imaging test, which could be x-rays, CT, MRI, or something called a PET-CT scan. I'm going to show you pictures in a moment. A bone marrow biopsy is how you really secure the diagnosis. A lot of times we're pretty sure somebody has myeloma before a bone marrow biopsy has been done, but the bone marrow biopsy is important, A, to secure the diagnosis, and B, to get some prognostic information, important information that helps guide treatment and also set expectations for patients. Next slide, please. So these are the imaging tests, and you can sort of see these are all pictures of somebody's spine. And you can see particularly, I'm going to draw people's attention to the one that says CT scan with the arrow. And you can see, you know, our backbone is really just a stack of cylindrical bones on top of each other. It's a column of bone. But if one of them gets a weak spot, one of those notches that I showed you before, it can wedge, it can collapse partially, and it introduces abnormal curvature in the spine. I mean, first of all, that's a fracture. It hurts. You lose height. Pieces of bone can push outward and pinch nerves. But also, it can dramatically change posture. It can introduce progressive curvature of the spine, which is very problematic for patients. And there are treatments for that, local treatments. You can inject cement into that bone and stabilize it. But the most important thing, obviously, when somebody develops lesions like this is getting the disease under control as quickly as possible. Hit the next slide, please. Okay. So I mentioned a bone marrow biopsy. This is not a great graphic. I'm going to step to the side here for one quick second. So when you put your hands on your hips like this, and I know it doesn't look like I have hips, but I have hips. If you put your hands on your hips like this and your thumb, where your thumb is resting, back here, that's the back of the wing of your pelvic bone. And that's where a bone marrow biopsy is performed. And it's not an operating room procedure. This is a bedside procedure. We do this in clinic. We numb it up, we prep it like we would in an operating room, but at the end of the day, you're pushing a needle into the bone and you're collecting cells from inside the bone to get, first, a count of the plasma cells, prove that the plasma cells are elevated, prove that the plasma cells are cancerous, and also, importantly, along the right here, to do certain genetic and molecular testing to help assign risk, to help assess prognosis, because there are certain chromosome abnormalities in the cancer cells. Now, these are not ones we inherit. These are not chromosome abnormalities elsewhere in your body, just in the cancer cells. But if you have certain ones, it predicts a more aggressive course. and it does modify the way we think about treatment, and we're going to get to that in some detail. Next slide. Okay, so we talk about risk. The bone marrow results with those chromosome tests, that's actually one of the major drivers of prognosis. But we also look at other things, like for instance, blood tests. Like if there are actually circulating myeloma cells in the blood at diagnosis, we call that plasma cell leukemia, that's bad. Plasma cells are supposed to live in your bone marrow. Also, if on imaging tests we see tumors of plasma cells, we call those plasmacytomas. If we see tumors of plasma cells in organs, like your liver or your lungs, that's bad. Those plasma cells are not behaving like normal plasma cells at all, and it's behaving in a more aggressive fashion than an average myeloma. So those have negative prognostic implications. The other one, the last thing I mentioned here, I called it old-fashioned doctor stuff. The stuff that any doctor should be able to do, like talk to a patient about their other medical problems and assess their overall activity level and frailty sort of status. There is actually something called a frailty score, which you can just plug certain factors about how a patient is functioning into this calculator, and it will spit out a frailty score. And somebody who's in a very frail status, that is actually as prognostically important as the high-risk chromosome changes. So we sort of minimize that. We minimize, we're very focused on the biology of the cancer, but we can't forget the biology of the rest of the person and the life and circumstances of the rest of the person, because that definitely factors into the prognosis of our patients. Next slide. So we've all heard repeatedly, thank you, Joe, about how old I am, which I appreciate that. But this is how we treated myeloma when I was when I was in med school. Okay, basically we would start with induction chemotherapy. That's what VAD is. I'm going to talk about that, but that's an abbreviation for a specific chemo regimen that we used back then. And then it was just about the time we started using stem cell transplant. And then after that, we would watch patients. And we would cross our fingers and hope that they had a lasting response to that transplant. And then, if things started heating up again, we would retreat them with one of the few chemotherapy drugs available in 1995. And after that, patients generally became increasingly ill, and it was hard to deliver therapy beyond that. And so survival was sort of dictated on A, the strategy that we used, and B, the drugs we had available at the time. Now, we've learned since then, hit the button once, that if you add maintenance therapy with a pill after transplant, even if you don't really change much of anything else, the induction regimen's changed a little bit, but even if all you changed was adding maintenance therapy, we know that that extends the response to transplant. And so right there, even if you didn't have something other than the original chemotherapy drugs that we had back in 1995, just adding maintenance improves the outcomes of patients. Now, fortunately, we have developed new agents, and with each new agent, one more time, survival keeps getting a little bit better, a little bit better, a little bit better, because we have a third line option, a fourth line option, a sixth line option, and, hit the button, we have actually also been working on the front end of this, and we've adjusted our strategy and added new and better agents to the induction before transplant and the maintenance after transplant, and pushed that part out too. And so you can see when we talk about survival doubling or really tripling since I was, coming out of med school, it's because of all of these improvements that we've made. New drugs added at the end, incorporated into the beginning, and the use generally of more continuous therapy. Okay? And I called the top regimen 1995. I'm going to call this last regimen 2020, because we're about, if we move forward to 2023 at the end, we're going to see that we're really about to make another major jump forward. Next slide. Okay, so I showed you VAD, and then the next one I had one called RVD. like what are these? Why do we do these abbreviations? Each one of those letters generally is referring to a chemo drug or some other kind of therapy. So we have all these different categories of drugs. We're not going through all these different categories, but the point is these are all actually totally different, unrelated classes of drugs. And what we usually do is we pick one from column A, one from column B, one from column D. If you hit the next slide, we have, so let's say, for instance, we pick lenalidomide from column A. Hit the button, please. You can just hit it one more. So you can sort of see that each one of these, when we talk about DRVD or DARA-RVD, daratumumab, Revlimid, which is lenalidomide, Velcade, which is bortezomib, dexamethasone. It's basically a cocktail of drugs picked from different classes of drugs to sort of hit the myeloma from different angles. And the analogy that Dr. McHale used was perfect. What we do in HIV treatment. When all we had was AZT, we did not have optimal outcomes in HIV management, but when we started combining it with other antivirals, all of a sudden, the virus was not able to outwit our therapy. And that's what we're shooting for with cancer therapy in general, is cocktails that hit the myeloma from different angles and overwhelm its ability to resist treatment. And that is an important issue. Plasma cells, normal plasma cells, are among the toughest cells in our body. Okay, they're designed to survive everything, right? I mean, that makes sense. It's our immune system. We need cells that are durable, with memory, that can recognize stuff that we were exposed to years ago, right? So the natural biology of normal plasma cells is tough. And then they acquire cancerous mutations, and they get tougher. And then we treat them with therapy, and they acquire resistance mechanisms, and they get tougher. So hitting them with multiple agents in first line, second line, third line is pretty much a staple of our therapy. Okay? Every time we try and switch therapies, if it's possible to give a cocktail of therapies, pulling from different columns each time, that's what we try to do. Next slide. We heard about stem cell transplant just briefly. The best analogy that I can think of, and it's perfect for this setting, Noah's Ark. Noah's Ark is sort of the comparison that I make with stem cell transplant. And this is what I'd say in clinic visits, right? And what's that story, right? In that story, there was a flood that wiped out everything, but what was on the ark? The seeds that were needed to sort of replenish the earth and all the different types of animals of the earth, right? That's the story. The flood in stem cell transplant is a super high dose of chemotherapy that's coming through, wiping out the myeloma, but taking with it everything else. Your bone marrow is collateral damage. But what have you done in that? What have you done to prepare for that? You've built your ark, which is really a bag of stem cells that's sitting in a freezer, right? That's waiting to be thawed out and given back to you after everything's washed through. And those cells can make their way back to your bone marrow, grow, and give rise to all the blood cells that you need to get. So you're not getting a transplant from somebody else. What you're getting, really, is a rescue package, right, of your own stem cells to prevent you from having the complications of the collateral damage of high-dose chemotherapy. And the high-dose chemotherapy is really effective at hitting the myeloma. And we know that, on average, there have been a couple of very well-conducted, large, randomized studies that show when you add transplant into the mix, disease control with that first line of therapy is longer. So in suitably healthy patients, there is still a good rationale for using this high-dose therapy, but it does take a lot of planning. Okay, next slide. So I basically just said this. We get longer responses. We also get better responses. We get deeper responses. You're more likely to be in a complete remission. And now we can measure remission with this ultrasensitive test called MRD testing. You can skip right through the next bullet. And I don't like the order that I put these in. MRD testing, I'm going to just talk about MRD, and then I'll skip through that slide a little bit later. MRD testing is an ultrasensitive test that can look for like one myeloma cell out of 1 million cells in your bone marrow. Okay, so that is a very, very, very deep level of disease suppression. What we know is, I'm going to skip forward. I want to actually get to that slide. This. Okay, hit the buttons, please. There, and one more, and one more. Okay, so what we know, think about myeloma like an iceberg. Okay, the sum total of the myeloma in your body is not just the part we can see above the water, it's the whole iceberg, including what's underneath, right? And from the perspective of that boat, all you can see is what's above the water. And when we get somebody into a complete remission, basically all that means is that you have reduced the myeloma to the point where there's nothing above the water anymore. That could be a 99.9% reduction in your myeloma. But when you started with a trillion myeloma cells in your body, right, that means you're still left with a sizable number of cells, potentially, in your body after a 99.99% reduction. Now, the chances of that reduction being even deeper is higher when you use better therapy. And we know that the deeper we suppress somebody's myeloma, the better. Okay, and transplant does help get to those deeper responses. And so the tests that we use can basically look for not just 99.99, but 99.9999% reduction. And so the deeper it gets, the better you will do afterwards, on or off of maintenance therapy. Okay, that's an important thing. In an era when we're hoping we'll be able to have more and more patients get breaks in their therapy, it's going to be important for patients to get to these ultra-deep responses so that they are more likely to be able to coast without reemergence of measurable symptomatic disease. Does that make sense? Yeah. All right, next slide. Okay, and we can skip through this slide. And in terms of what we're trying to achieve, again, cocktails of therapy to get fast disease control. Deep responses help us get durable disease control. Maintenance therapy, whether you're in that deep response or not, probably is helpful, regardless of the depth of your response. An early decision about stem cell transplant, and an important principle I want to get to, which is don't save the best for last. There's this, some people like to think about myeloma as a chess match, and they're thinking 3 moves ahead. They're like, well, if I use A, B, and C now, I won't have B and C later. But the fact of the matter is the best strategy is always coming out swinging, next slide, with your best line of therapy that's available at that moment. Second line therapy may not, on average, work quite as well as first line therapy, but you don't want to give second-rate second line therapy. Okay, you don't want to save things hoping to have them for later because, if you can hit this again, what we see one more time, what we see as we go from line to line to line of therapy, the number of patients who haven't died and who have stayed healthy enough to actually get and benefit from therapy goes down over time. So it's not that every patient gets second-line therapy. In fact, you have a 10 to 20% drop-off with every line of therapy when you look at the SEER data that Joe mentioned earlier. Okay? We lose patients still. Even though myeloma therapy is better now than it used to be, we still lose patients along the way to disease, to complications. Okay? And so the idea of withholding therapy and increasing the chances that somebody's myeloma is going to be uncontrolled sooner, and it increases the chances that they're not going to make it to that next line of therapy down the road. And I focus on this a lot in my clinic when I'm talking with patients. Okay, it's getting a response and getting a durable response. The durability of a response is really, really important. We want the response, but we also want to, if our what's third line therapy going to be for you conversation happens tomorrow, it's different than if it happens in 3 years. I guarantee that in 3 years, the regimens we'll be talking about are different and better. So we like to get durable disease control. Next slide. Next slide. Okay, so let's talk about briefly, we're going to talk about just relapse disease. What do we do after first-line therapy? Well, I mean, basically when we're selecting these regimens, we're still picking from the same group, the same selection of treatments, and we still try and do triplets or doublets or combinations as long as we possibly can. Next slide. And how we pick them depends on a lot of different factors. How well did first-line therapy work? Were they still on it when their myeloma started getting active? What kind of side effects did they have? What other medical problems have developed? So all of those things come into play, and we try and come up with personalized approach to selection of therapy at each line of therapy. Next slide. We talk about access to clinical trials. You're not going to find somebody who's a bigger believer in clinical research than me, maybe Dr. Cole, maybe Dr. McHale, I'm not sure, but I'm a pretty strong advocate for it. But the reality is there are potential obstacles to getting on trials. Sometimes it's simple things like the amount, like certain side effects or problems that a patient has, the kidney function, their blood counts just exclude them because they don't meet the eligibility criteria for a study. Hit the button for me. Sometimes, I think one more. Sometimes it's much more mundane things, but they're just as real. Like a trial is very competitive and it's hard to get a slot on a sought-after trial. Sometimes, and this is a problem for a network like the Karmanos Cancer Institute sometimes, we have patients that visit us from all over the state. And if a study involves a visit twice a week on an ongoing basis, that might work if you live a mile away, but it doesn't work as well if you live 100 miles away. So sometimes there are very practical obstacles to clinical studies. One of the most important ones, though, that isn't on here is simply not being offered a clinical study, some sort of implicit bias that leads you to think, I don't think this person would want to be on a study. And I advocate strongly and I instruct our fellows strongly to not make those assumptions. In fact, interest in clinical studies, our experience has been generally that when you offer clinical studies to diverse patients, the African American community, Hispanic community, Arab American community, generally speaking, they're all interested in hearing about studies, just as interested in as anybody else, but you have to actually offer the studies and talk about them. Next slide. All right, so I'm going to finish by talking about two basic kinds of immune therapies. So we have this whole new wave of drugs that target something on myeloma cells called BCMA. It's a marker on the surface of the myeloma cell that we can take advantage of and target. We had an antibody, a new type of antibody that had toxins attached to it. That was called belantamab. That unfortunately, please hit the button, was withdrawn from the market because of the results of a study. It had an initial approval, but its final approval ended up being withdrawn. That came off the market, but we now have two cellular therapies called CAR T-cell therapies that are available that both target BCMA. And CAR T-cells are your own immune cells collected from your blood like we collect stem cells before a transplant. And we take those cells and we send them off to a lab where they're modified so that they have these receptors on the surface of the cells that let them attack your cancer. Normally, cancer evades our immune system pretty well, but we can modify these immune cells so that they can track down, bind to, and attack your myeloma cells. Incredibly effective therapy. I mean, the response rates, right now, these are approved for people who've had 4 lines of therapy before that. And the response rates are in the 70 to 100% range. And I can tell you that, many of those responses are complete MRD negative responses. So this is incredible therapy. And I think within the next year, we're going to see these cells being used earlier than they're currently being used. That's coming. There's also another type of immune cell in between regular antibodies and CAR T cells, which, if you hit the button, basically they're called bispecific antibodies, and the reason they're called bispecific is because these antibodies, instead of a normal one, where each prong on the end of the antibody binds the same thing, with bispecific antibodies, one more time, one of them binds immune cells, one of them binds myeloma cells through BCMA. It forms a bridge, and it basically redirects your immune system right up to the myeloma cell, hit the button, where it can then attack the myeloma cell. So it's a different way of engaging the immune system. Instead of taking your immune cells out and modifying them so that they can fight the myeloma, what these antibodies do is they redirect the immune cells without having to modify them so that they can find the myeloma cells by way of this sort of immune bridge. Next slide. Just like stem cell transplant, CAR T cell is a process. You have to collect the cells, you have to process the cells, you have to reinfuse the cells, and if you hit the button, there are some sort of time choke points in this, some bottlenecks in this process, because a lot of people want these, and so there's built-in time waiting to get to the CAR T cells, and then time waiting for them to be manufactured and modified. Hit the button. So we often need to give what we call bridging therapy. This is actually one of the hard parts of CAR T cells, because where they're approved right now are people who've had 4 lines of therapy. So when you're trying to control the disease for 6 weeks or 12 weeks while you're waiting for CAR T cells, you're trying to control pretty resistant disease. When we can start moving this forward and using it to chase therapy that works better, that bridging therapy is going to be a lot more effective at keeping the lid on the myeloma while we're waiting for the CAR T cells. Next slide. I think it's my last slide, actually. So we're expanding the manufacturing so it'll be easier to get them. We're reducing the time it takes to manufacture them. That will reduce that waiting time. And then, as I said, we're moving them forward. The other interesting thing is there are some companies working on what we call allogeneic CAR T cells, where instead of collecting your own cells and then modifying them, they just have off-the-shelf, already modified T cells from donors. And so that eliminates the whole manufacturing period, right? And those are just ready to go. So that will also reduce the time frame. So we have a lot of strategies here to try and make CAR T cells more available to patients. And when you have therapy that works as well as bispecifics and CAR Ts in 4th and 5th and 6th line therapy, we can be pretty certain that it's going to work even better when we can use it earlier. And also, it will be available to a lot more patients, because as I showed you, there are more patients who are candidates, and well to get 2nd line therapy than to get 4th line therapy. So more patients, a higher percentage of patients diagnosed with myeloma in 2024 are going to have access to CAR T than patients who were diagnosed 6 years ago or 8 years ago, who are just had the opportunity to start getting them in the last year or 2. I think that's kind of my last slide. These are conclusions, but you can just kind of scroll through these. These just drive home the points I was just making, and I really appreciate the chance to talk with all of you today. Thanks.